Let's just get this started. Give me a second. Yes. Okay. So I think we are good. Okay. So yeah, yesterday we had stopped at uncomplicated UTI, which is not uncomplicated UTI, treatment of UTI. We are stopped in treatment of UTI, which consists of uncomplicated and prosthetic infection and complicated. So in case of uncomplicated, you have trimethoprim sulfonamide, ciprofloxacin, ampicillin, tetracycline. All of them you can give. In case of prosthetic inflammation, you give chlortrimoxazole, ciprofloxacin, and ampicillin. Same shit. But in complicated, you give gentamicin, tobramycin, and ampicillin. This is same. And going on. So this is UTI. So we move on to acute bacterial pyelonephritis, which is inflammation of the kidney, pyogenic inflammation of the kidney. So women is more than men because short urethra and proximity to anus. So route of infection is ascending infection from the urethral meatus, or it can be descending from hematogenous. And you have predisposing factors. You have obstruction, you have congenital anomalies, renal caniculi, and ureteral occlusion. You have vesicourethral reflex, which was taught before also, and you have residual urine in bladder. Same three features which was there previously also. Instrumentation also, indwelling urinary catheter and stuff like that. It was there here also. Yeah, obstruction, vesicourethral reflex, renal residual urine in bladder, and instrumentation of urinary tract. The same reasons will come here also. Then causative agents: E. coli, Klebsiella, Enterobacter, Proteus, Pseudomonas, Staphylococcus, if you want, you can write. So clinical features: you will be having chills, fever, flank pain, nausea, vomiting, costovertebral angle tenderness, increased frequency, and dysuria. Urine specimen will show CFUs, and you have to check ultrasound or CT for obstruction or renal peripheral abscess. Antibiotics you can give: fluoroquinolone, ampicillin, gentamicin, third generation. Cephalosporin. You would not give nitrofurantoin because effectiveness has been proven only in lower urinary tract infections. Then microalbuminuria. Microalbuminuria is excretion of albumin 10 to 20 to 200 grams per minute. Okay, so daily excretion in the range of 30 to 300 mg. That is microalbuminuria. It is caused by diabetes mellitus with early renal involvement and hypertension, myocardial infarction, acute phase response, obesity, hyperlipidemia, alcohol intake, and physical exercises. Basically, some damage is there in the glomeruli leading to excretion of albumin. 20 to 200 microgram per minute albumin excretion rate, or daily excretion in the range of 30 to milligram, 30 to 300 milligrams. Okay, so proteinuria variant normal is less than 30, micro is 30 to 300, and macro is more than 300. So proteinuria, urine protein composition, you can have a Tom Horsfall protein, you can have blood group related antigen, albumin, mucopolysaccharides, in immunoglobulins, hormones, enzymes, etc. So classification of proteinuria: obviously it is divided into glomerular proteinuria and tubular proteinuria. So if there is injury to the glomerulus, it is affecting albuminuria more than 3.5 gram per day, then it is glomerular proteinuria. If there is injury to the tubules and there is failure to reabsorb proteins filtered by glomerulus and release of Tom Horsfall protein is there, it is tubular. And primary glomerular diseases, you have minimal change: MPGN, FSGS, MGN, and RPGN, which is okay, fine. Myeloproliferative, focal segmental, what is this? Mesenchymal, and rapidly progressive, or something like that. I forget what the RPGN is. Okay, then moving on, you have this is glomerular proteinuria. Hereditary, you have Alport syndrome and Fabry's disease. Infections, you have bacterial endocarditis, PSVN, post-streptococcal infection, glomerulonephritis, secondary syphilis, hepatitis, HIV, malaria. Immunological, you have SLE, estrogen, HSP, Wegener's granulomatosis, Goodpasture syndrome. Drugs, you can have penicillinamides, lithium, NSAIDs. All of this will cause glomerular proteinuria. Particularly, you have polycystic kidney disease, medullary cystic disease, pyelonephritis, tuberculosis, metabolic, you can have diabetes mellitus, hyperuricemia, uricosuriia, hypercalciuria, oxalosis, cystinosis, etc. Immunological Sjögren's syndrome, obviously, renal transplant rejection, and drug hypersensitivity, sarcoidosis. Toxic injury, you can have drugs, radiation, and poisons. So, overflow proteinuria is filtration by normal glomerulus of large amount of small molecular weight protein. Multiple myeloma, hemoglobinuria, rhabdomyolysis cannot be overflow proteinuria. Other types of proteinuria, you have benign orthostatic proteinuria in adolescence, and transient proteinuria. It is associated with cardiac failure, fever, and heavy exercise. Okay, so going on, you have renovascular hypertension. It is systemic hypertension that manifests secondary to but complication to blood supply to the kidney. This is basically secondary hypertension. Renal artery stenosis, mostly secondary to atherosclerosis, fibromuscular dysplasia, arteriitis such as Takayasu, Apla, and mild aortic syndrome, extrinsic compression of renal artery, dissection or infection and radiation, fibrosis, all lead to renovascular hypertension. So pathogenesis. So you have decreased perfusion to the kidney, activation of RAAS pathway, and angiotensin 2 to vasoconstriction. Secretion of aldosterone, sodium, and water retention, increasing the blood pressure, and increased synthesis of collagen type 1 and 3, leading to thickening of vascular wall and myocardium. So basically, there is decreased perfusion to the kidney. RAAS pathway is activated. This leads to angiotensin 2 to vasoconstriction. And this again leads to secretion of aldosterone, retention, and raising the blood pressure. Increased synthesis of collagen type 2 and 3, leading to thickening of the blood wall of vessel wall and myocardium. Okay, so clinical features: resistant hypertension, uncontrolled BP requiring use of more than 2 hypertension. Then you have antihypertensive drugs, one of which is a diuretic, and you have raised blood urea nitrogen and creatinine. Investigations you can do based on BMP. I genuinely do not know what BMP is. What are they talking about, man? Blood pressure analysis? No, you check BP, I know. What is BMP? Central mean pressure? Some shit like that. And genuinely do not know what these both are. But you check the urine analysis, you perform plasma renin aldosterone ratio, CT angiography, ultrasound of the kidneys you can do, blood monitor, BP. Honestly, I'm just going to call this as BP. Treatment, you have antihypertensive drugs which you take more than 2, including one diuretic, and percutaneous angioplasty is the treatment of choice. And complications, you have renal failure, myocardial infarction, stroke, pulmonary edema, retinopathy, congestive heart failure, etc. etc. Renal osteodystrophy or osteitis fibrosa cystica. It is due to chronic renal failure. It leads to chronic hypocalcemia, secondary hyperparathyroidism, calcium reabsorption from the bone. So you'll be having bone pain, fractures, osteomalacia, osteosclerosis. You have Jugger's, I think it's called Jugger's, some spine and all, it will be affecting, it will lead to osteomalacia, osteosclerosis, and also treatment is improving calcium and phosphate level. Sinacet, which is oral calcium mimetic agent, increases sensitivity of calcium sensing receptors, and you have parathyroidectomy, which is given for severe cases. Then you have nephrolithiasis, which is again stones in the kidney predisposed by volume depletion, lack of stone inhibiting protein in urine, osteoporosin, pontin, and nephrocalcin, and hereditary predisposition to stone, errors of metabolism like gout, cystinuria, primary hyperoxaluria, and infections. You have urea splitting streptococci, staphylococci, and proteus. So decreased urine citrate, which binds to calcium to prevent stone formation. Urinary pH, you have acidic for cysteine and uric acid, and alkaline for struvite and calcium stones. So types of stones, you have calcium oxalate and calcium phosphate, struvite or triple stone, which is magnesium, aluminum, and phosphate, uric acid, cysteine, and indinavir. Then that's it for renal disorders. We move on to hematology. Hematology, you start with anemia. Anemia is conditioned by marked by hematocrit and hemoglobin less than 41%, and hemoglobin less than 13.5, less than 12, less than 14, less than 12. That's how I remember it as. Hematocrit less than 41%. Okay, that is definition. Then for classification, you can have blood loss due to impaired RBC production and due to hemolysis. So in blood loss, it is due to trauma, GIT lesions, and gynecological disorders. Impaired renal cell production, it can be due to nutritional deficiency, iron, B12, B9, vitamin C, genetic defects like thalassemia, Fanconi's anemia, and erythropoietin deficiency, aplastic anemia, anemia of chronic diseases, hematopoietic neoplasms, ALL, MDS, myelodystrophy. MPD. But genuinely, I do not know MDs. What do you mean by MDS, MDP, MPD? Okay, fine. Parvovirus B12 infection. No idea what MDS, MPD is. I'm not going to teach. So hemolysis, you can have intrinsic, which can be hereditary spherocytosis, hereditary elliptocytosis, G6PD deficiency, paroxysmal nocturnal don't know what PND is. PNH. Hemolysis. Proximal nocturnal hemolysis? Maybe. Pyruvate kinase deficiency, thalassemia, sickle cell disease, and in extrinsic you can have antibody mediated destruction, which is erythroblastosis fetalis, transfusion reactions, drug associated, you can be having SLE, and microangiopathic hemolysis, which is HUS, and DIC, TTP, etc. What is it? Thrombocytic, idiopathic thrombocytic purpura, thrombocytic puric purpura, etc. DIC, and infection, you can be having malaria, babesiosis, hypersplenism, and defective cardiac valves. All of these will lead to hemolysis, impaired cell production, of course, hemolysis, chronic disease, wait, give me a second. Mm. Okay. Actually, they never told what pNH is anywhere in the next, so I don't think it's really that important. So going on, we have iron deficiency anemia. Mm. Okay. Causes of iron deficiency anemia, which is increased iron demand, physiological iron loss, pathological iron loss, decreased iron intake. So, increased iron demand, you have postnatal growth spurt, adolescent growth spurt, erythropoietin therapy, and pregnancy. And in physiological iron loss, it is due to menstruation, pregnancy, gastrointestinal bleeding, genitourinary bleeding, pulmonary hemochromatosis, and intravascular hemolysis. Decreased iron intake is like a cereal rich diet, pica, and malabsorption. So increased demand, of course, during growth and pregnancy. Physiological iron loss, menstruation and pregnancy. Pathological iron loss, which is GI bleeding, urinary bleeding, bleeding, hemocytosis, hemolysis of any kind. Then decreased intake, which is cereal rich diet, pica, and malabsorption. So requirements: in male it is 1 mg per day, female it is 2 mg per day, pregnancy it is 3 mg per day. Very easy to remember. Stages: you have negative iron balance, deficit erythropoiesis, and iron deficiency anemia. Clinical features: you can have fatigue, poor exercise tolerance, pallor, dyspnea, syncope, tachycardia, palpitations, systolic erection, brittle nails, koinokia, chylonychia, which is spoon-shaped nails, glossitis, stomatitis, pica, which is craving for non-food substances, food, ice, soil, fishes, etc. Then Plummer-Wilson syndrome, which can have post-record web and menorrhagia. All of these could be the clinical features of iron deficiency anemia. So investigations: you can do peripheral blood, peripheral smear, and biochemical analysis. So peripheral blood hemoglobin will be decreased, hematocrit will be decreased, anemia. Red cell indices, mean corpuscular volume will be less than 85 fecolitres. MCH will be decreased, MCHC will be decreased. Everything will be decreased on the board. And in peripheral smear, you have microcytic hypochromic RBCs. You can have anisocytosis and pychocytosis. Basically, you'll be having microcytic hypochromic anemia, abnormal shape of the cells, and loss of symmetry of the cells, I think. Then you can have biochemical assay. You can do serum ferritin will be decreased, transferritin saturation will be decreased, and transferritin will be over TIBC, which is transferrin will be increased, saturation will be decreased, transferrin will be increased. Saturation means the amount of iron which is bound will be decreased, but the total number of binding protein, total iron binding protein, TIBC, total iron binding protein will be increased. Protein or binding cells. Okay, so management: you can give a vitamin C supplementation, which increase the iron absorption and iron requirement. So you can do it as a total dose deficit times lean deficit. 1 second. Deficit times body weight plus 1000 that's it. Gram per deciliter times body weight, lean body weight plus 1000. This is for storage, this is for refilling. So you have 2 ml of dictionary contains 100 mg of iron. So hemantics, so you can have iron, oral iron, you have ferrum sulfate, ferrous fumate, you can have ferrous gluconate, stuff like that. And maturation factors, you can have vitamin B12, folic acid, adjuvant hemanthinics, we have copper and pyridoxine and riboflavin. So partial classification of anemia, you have microcytic, macrocytic and normocytic, each with their volume, Okay, so microcytic anemia is thalassemia, sideroblastic anemia, lead poisoning, myelofibrosis, Hodgkin's lymphoma, EDA, okay, IDA, iron deficiency anemia, obviously. Okay, then you have macrocytic anemia, which is vitamin B12 and B9 deficiency. You have myelodysplastic syndrome, liver diseases, reticulocytosis, hydroxyurea treatment, and excessive alcohol intake. And normocytic, you have intrinsic causes, which is aplastic anemia, PNH, and myelodystrophic syndrome, congenital dyserythropoiesis. Extrinsic causes, you have erythropoietin insufficiency, anemia of chronic diseases, marrow infiltrative disorders, hemolytic anemias, drug associated, toxin associated, and radiation associated, obviously. Okay. So you have, of course, the differential diagnosis of generalized lymphadenopathy. You have lymphomas, leukemias, disseminated tuberculosis, HIV, secondary syphilis, infectious mononucleosis, brucellosis, SLE, again. Okay, fine. Metastatic disease, local inflammation, stuff like that. But generalized lymphadenopathy, you can write on your own a lot of things. Lymphomas, leukemias, disseminated TB, you can write HIV, SLE. More than enough. Yeah. They'll ask only like one question, 6 reasons of generalized lymphadenopathy. Okay, so next we move on to blood transfusion indicated in what do you say, blood loss in RTA. Fine. Blood loss in surgery, severe anemia, iron deficiency, thalassemia, aplastic anemia, anemia of chronic illness, connective tissue disorders, and malignancy. You can have bleeding disorders, you can have extensive burns. So 1 unit of RBCs indicates improves hemoglobin by 1 gram per deciliter. So first of all, you take whole blood, you do centrifugation, you'll get packed cell volume, and you get plasma rich protein. You again do centrifugation, you'll get platelet concentration and fresh plasma, or platelet poor plasma. That you can again divide it into fresh frozen plasma and cryoprecipitate. So complications, you're gonna have infectious complication, HIV, HPV, AIDS, malaria, cytomegalovirus, syphilis, etc. Non-infectious, you can have transfusion reaction, febrile non-hemolytic reaction, allergic reaction, transfusion related, lung injury, air embolism, circulatory overload, hypothermia, citrate intoxication you can have. Did you have transfusion associated GVHD? I have no idea what GVHD is. Iron overload is there and thrombophlebitis. Heart disease. I don't know what HD is. Okay, leave it. Okay, okay, just give me a second. I need to drink some water. Okay, sorry. Took a lot longer. Give me a second. Okay, so pancytopenia. Pancytopenia. So pancytopenia is, of course, raised amount of pancytopenia is decreased amount of RBCs, neutrophils, and thrombocytosis. It is caused by aplastic anemia, myelodysplastic syndromes, bone marrow infiltration due to leukemia, lymphoma, and myeloma, and megaloblastic anemia, B12 deficiency, folic acid deficiency. Okay, no, I'm going to check out what PNH is. Give me a second. PNH. Yeah, it's paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Myelofibrosis and hypersplenism. Give me another second. So PNH is rare acquired blood disorder, causes RBC to break down prematurely. It occurs due to a genetic defect. It cannot affect anyone. Mean age of onset is in 30% people. So your immune system attacks your own body. That's the basic gist of it. Okay. So going on, you have bone marrow transplantation indicated by oncological and non-oncological. Oncological AMM, ALL, CML, multiple myeloma, Hodgkin's and non-Hodgkin's, and neuroblastoma. So non-oncological, you have aplastic anemia, beta thalassemia, minor, major, myelodysplastic syndromes, paroxysmal, they expanded here. Why cannot they expand there? Okay. Bernard Solar syndromes, Higashi syndrome, severe combined SCID, immunodeficiency, adenosine deaminase deficiency, A gamma globulinemia, George Wiskott Aldrich syndrome, etc. So types of bone marrow transplantation, you have syngeneic, which is donor and recipient are identical twins. Allogenic, which is different genetic origin but same species. Autologous, which is removal of marrow, chemoradiotherapy, and transfer of patient's own marrow. And you can have complications. You can have graft versus host reaction and opportunistic infection. So graft versus host disease. This is GVHD. So here you can see transfusion associated graft versus host disease. Okay, it occurs following allogenic transplantation of blood, bone marrow, and organs. So here you have donor T lymphocytes, CD4 plus CD8 cells reacting against the recipient's tissue organs. So it is due to HLA mismatch. You have acute, which occurs less than 300, and chronic, which occurs more than 100. You'll be having skin rash, diarrhea, liver dysfunction, corrective conjunctivitis, sicca, lichenoid changes of buccal mucosa, and sclerodermatous changes. Okay, then you have blood related drugs. You have antiplatelet drugs, which is COX-2 inhibitor, aspirin, P2Y12 inhibitor, which is clopidogrel, ticlopidine, maybe you can remember. You have GP2 2B3A inhibitor, which is abaciximab, and you have phosphodiesterase inhibitor, which is dipyridinamole, and silostazole. Okay, then you have anticoagulants. You have parenteral and you have oral anticoagulants. Parenteral anticoagulants, you can okay, anticoagulants, fondaparinux, and low molecular weight heparin, unfiltered heparin. I'm just saying what DTA ITI is. I'm not sure what DTA ITI is. Heroidine, maybe. None of these are rememberable. You can remember only fractured heparin fracture, unfiltered heparin filtrate, maybe low molecular weight heparin, and fondaparinux. Then in oral you can have coumarins, which is warfarin, bis hydroxycoumarin, and 10A inhibitors you can have, which is ivaroxaban, bituximab. None of this you can actually remember very well. Yeah, low molecular weight heparin you can fondaparinux, exoxaparin, and fondaparinux. It is indicated in unstable angina, thrombosis associated with myocardial infarction, deep vein thrombosis, post-MI, cutaneous surgery, and stenting. I don't know what PE is. A lot of this they have used in this part. I really do not know what PE is. Peripheral edema. Okay. Megaloblastic anemia, macrocytosis more than 100 femtoliters. So it is caused by B12 deficiency and B9 deficiency. Myelodysplastic syndrome, liver disease, reticulocytosis, hydroxyurea treatment, and excessive alcohol intake. So B9 deficiency can be due to topical sprue, gastrectomy, intrinsic factor deficiency, diphyllobothrum latum infestation. It can be due to increased demand and hyperthyroidism, disseminated cancer. There is also isolated B12 malabsorption, which is seen in I'm not even going to try to spell it. It's seen in the disease, but you cannot remember it. Leave it. Malabsorptive states, again celiac disease and tropical sprue for B9 deficiency, anticonvulsant therapy, phenytoin, phenobarbital, antifoliate drug, methotrexate, trimethoprim, and you have increased demand in pregnancy, hyperthyroidism, and disseminated cancer. Anticonvulsant and folate therapy, that is the important point. Fine. So pathogenesis, you have gopalamine and folic acid are involved in DNA synthesis. Deficiency leads to impaired DNA synthesis, delayed nuclear maturation compared to cytoplasmic maturation, leading to megaloblastic changes and pancytopenia. Basically, there is delayed nuclear maturation. That is the only important thing you can remember. So you have clinical features, you have anorexia, hypotonia, hyperpigmentation of the knuckles and terminal phalanges, fever due to neutropenia, bleeding due to thrombocytopenia, hepatosplenomegaly, diffuse atrophic gastritis, you have achlorhydria, glossitis with beefy red tongue, and bilateral peripheral neurectomy, glove and stalk, distribution of glove and stalk numbness or paresthesia, and hyperhomocystinemia, atherosclerosis, subacute degeneration, demyelination, ataxia, uncoordinated gait, impairment of vibration and position sense. All of them can be seen. So investigations, you can do peripheral blood investigation, peripheral smear, you can do biochemical findings, you can do. So peripheral blood, you can have hemoglobin will be decreased, hematocrit value will be decreased, mean corpuscular volume will be more, MCH is decreased, MCHC is normal. One volume is increased, concentration MCH is decreased, MCHC is normal or decreased technically. MCHC is MCH by MCV. It should be decreased. I don't know why they've written normal. Okay. Hematocrit is decreased. That's why they have written it as normal. Okay. Peripheral smear, you can have ovulocytes, you can have RBC with lacked central pallor, you can see Havel-Joel's body, which is nucleus, hypersegmented neutrophils, you can see pancytopenia will be there, anisopychocytosis will be seen. And the shape of the RBC is symmetrical, abnormal. Okay, so biochemical findings, you can have homocystinuria, melanonuria, B9 deficiency, homocystinuria, no melanonuria, that's only difference. Methylmelanonuria, it is present only in this thing, B12. Okay, so we can do Schilling's test also to differentiate B9 deficiency caused by pernicious anemia or malabsorption. You can have Figlu excretion test. Folic acid deficiency, Figlu cannot be metabolized, excreted in urea unaltered form, aminoglutamic acid. This is important thing. So management for B12 deficiency, you can give hydrocobalamin 1 gram mcg, microgram 1 mg twice during first week. You can give for cyanocobalamin per month for lifelong. Okay. Rapid regeneration of blood depleted iron reserve, you can give ferrous sulfate 200 mg daily. Folate deficiency, 5 mg of folic acid per day orally. 350 mg is given for all pregnant women, and methotrexate therapy 15 mg daily orally you should give folic acid, and you treat the recurrent infections and underlying cause you have to treat. Then hemolytic anemia, it is resulted from increased RBC destruction in presence of normal or increased erythropoiesis. So you have premature RBC destruction less than 120 days, elevated erythropoietin, you have increased hemoglobin catabolites, which is bilirubin. So it is caused by intrinsic and extrinsic causes. You can have intrinsic, you have hereditary spherocytosis, elliptocytosis, G6PD deficiency, paroxysmal nocturnal hemoglobinuria, anemia, pyruvate kinase deficiency, thalassemia, sickle cell disease, etc. Extrinsic causes of hemolytic erythroblastosis, transfusion, drug associated SLE. You can have microangiopathic hemolysis, hemolytic uremic syndrome, DIC, TTP. Infections can be malaria, babesiosis. See, this is the same thing which you have written over here. Previously, we have seen the same thing. So I'm just going to erase this entire thing. Same as above. So clinical feature, you can have what do you say? You can have intravascular hemolysis, anemia, jaundice, splenomegaly, and decrease in haptoglobulin. And you can have intravascular hemolysis, anemia, jaundice, hemoglobin, severe decrease in serum haptoglobulin, and hemoglobinuria, hemosideruria, etc. So investigation, you can have peripheral blood, hemoglobin will be decreased, reticulocyte will be increased, peripheral smear RBC, you will have nuclear-sided sickle cell, target cell, acanthocyte, cystiocyte. This is in malaria. You can have all those images you can see. Bone marrow, you can have erythroid hypoplasia will be there, ME ratio will be decreased. I forget what ME ratio is. Erythroblast by WBC, myeloproliferative cells, erythroblastic cells. Myeloblast to erythroblast ratio will be decreased because erythroblast ratio will be increased. Erythroid hypoplasia is there. That's why erythroblast ratio will be increased. Okay, hereditary spherocytosis, you can have inherited abnormality of RBC membrane. It is having mutation in spectrin, ankyrin, and protein 4.2. So RBC membrane protein mutation is there. Membrane loss due to hemodynamic stress of blood flow, decrease RBC surface areas, formation of spirocytes, and spirocytes are rigid and inflexible, premature destruction, trapped and destroyed in spleen, extravascular hemolysis. So clinical features, you can have anemia, splenomegaly, jaundice, pallor, pigment gallstone, aplastic crisis. Upon superadded parvovirus B19 infection, you have hemolytic crisis due to Epstein-Barr virus involvement. So complications, you can have gallstones, aplastic crisis, hemochromatosis, and hepatic failure. So investigations, peripheral smear, you have bone marrow and biochemical examination. Yeah. So in peripheral smear, you have spirocytosis, RBCs without central parallel, and total leukocyte count is increased. Total reticulocyte count is increased. In bone marrow, you have erythroid hypoplasia. Biochemically, you have serum bilirubin will be raised, urine urobilinogen will be raised, and serum haptoglobulin will be decreased. Osmotic fragility test will show increased osmotic fragility. So treatment, you can do splenectomy. Prior to splenectomy, you can do polyvalent pneumococcal vaccination and administration of prophylactic penicillin in post splenectomy period. Moving on, we get sickle cell anemia, qualitative defect in hemoglobin synthesis. So, substitution of glutamine bivalent in 6th position of beta globulin chain. There is also a drug which it is. Mission's point nutrition. GUG to GAG it will become. So, in low oxygen tension or deoxygenation, HPS molecules undergo aggregation and polymerization. Aggregated molecules become long needle-like fibers known as tectoloids within the RBCs, and RBC becomes elongated and assumes shape like a sickle cell. It predisposes to stasis and vascular occlusion. So clinical features: presence of HbF in the first 6 months has protective role against HBS. So symptoms appear after 6 months as the HbF decreases. So sickling crisis, you have veno-occlusive crisis, blockage of microcirculation by triggered RBC, hypoxic injury and infection will be seen. Bone, you can have hand-foot syndrome, dactylitis of bone and feet. Lung, you can have acute chest syndrome, which is very dangerous. It is actually an emergency. Spleen, you can have splenic infection and eventually you will have autosplenectomy. Sequestration of crisis, you can have sudden trapping of blood in the spleen or liver leading to rapid congestive enlargement of the organ. You can have a drop in hematocrit leading to hypovolemia. So increased susceptibility to acute infections is seen. So pneumonia due to pneumococcus, meningitis due to the same, and osteomyelitis due to salmonella. Okay, so investigations, you can have peripheral blood, you have peripheral smear and serum findings. So peripheral blood, of course, hemoglobin will be decreased, hematocrit will be decreased, ESR will be reduced, and reticulocyte count will be increased because of hypoxia. So you can have an sickle cell, target cell follow. No, sickle cell is the only thing which is important here. Sickling of cell will be seen. Then serum findings, you'll have hyperbilirubinemia, gallstones formation, raised serum iron and ferritin will be seen. Haptoglobin will be reduced, neurobilirubin will be increased. You can say it's due to obstruction, gallstones obstruction, neurobilirubin will be increased. Okay, diagnostic or confirmatory tests, you have obviously HPLC, high performance liquid chromatography is the main thing, hemoglobin electrophoresis, estimation of HbF. Then treatment, you can give pneumococcal vaccination and prophylaxis, rigorous treatment of infection, analgesic therapy for crisis, blood transfusion therapy, bone marrow transplantation, and hydroxyurea, which increases the hemoglobin fetalis level and it reduces sickling. Next, we have thalassemia, which is an inherited disorder due to abnormality of globulin production. So it decreases or absence of either synthesis of alpha or beta. So beta thalassemia syndromes is beta chain, alpha thalassemia syndrome is alpha chains. So pathogenesis, you have impaired or absence of synthesis of one globulin chain leads to inclusions of another globulin chain inside the RBC. RBC with single globulin chain are removed by extravascular hemolysis. So clinical features, you have moderate to severe anemia, untreated untransfused children fail to thrive and die within 4 to 5 years of age. Without transfusion, without treatment, they will die. So thalassemia phases, you have chipmunk face, prominent forehead, cheekbones and upper jaw. Extramedullary hemopoiesis, hepatomegaly, you can see marked splenomegaly will be there. Iron overload will have due to multiple blood transfusion. Secondary hematochromatosis of the heart, liver and the pancreas will be seen. Moderate to severe anemia, they will just die. Chipmunk face is prominent head, forehead and upper jaw. They will appear like a chipmunk, and extramedullary hematopoiesis will be there, and also obviously hepatomegaly, marked splenomegaly, iron overload. So investigations, you can check peripheral blood, peripheral smear and biochemical findings, same as always. So in the peripheral blood, hemoglobin will be reduced, anemia, hematocrit will be markedly reduced, anemia, reticulocytosis will be there, and RBC indices decreases, all of them. In peripheral smear, RBC will be having microcytic hypochromic anemia and anisocytosis, pachycytosis, basophilic stippling. Basophilic stippling is common, is seen only in thalassemia, and then target cell also formation will be there. So WBC, leukocytosis with prematurity, left shift is prematurity. Platelets will be normal. And biochemical findings, you have bilirubin will be increased and conjugated bilirubin will be increased. Urinobilirubin will be increased, serum haptoglobin will be reduced, serum iron will be increased, and serum ferritin will be increased. Ferritin saturation also will be transferrin saturation will be increased, and total iron binding capacity will be reduced. So special tests, you have fetal hemoglobin, HbF, it will be increased. Hemoglobin electrophoresis you can perform, and Nestroff test, naked eye single tube red cell osmotic fragility test, Nestroff. Then, so radiological findings, you can find X-ray skull. You have hair on head, crew cut appearance due to extramedullary hematopoiesis. Long bones, metacarpals and metatarsals, you have thinning of cortex, widening of medulla. So it is marrow hyperplasia. Treatment, you give blood transfusion, folic acid supplementation, human recombinant erythropoietin, allogenic bone marrow transplantation. Using a matched signaling or is usually curative. For curative, blood transfusion or else is given 3 to 5 week intervals, iron supplement, folic acid supplementation, human recombinant erythropoietin. Okay, so moving on, we move on to hemophilia, which is a X-linked inherited bleeding disorder commonly affecting male child because it's X-linked. Hemophilia A is deficiency of factor 7, B is 9, and C is 11. Manifestation, you have excessive bleeding will be there, contusion, hematomas at sites of minor trauma, epistaxis, bleeding after tooth extraction or tonsillectomy, hemarthrosis, knee, elbow, joints and all. So it is due to inflammation and degenerative changes. Bleeding may go into JIT, all other places. Have fixed joint. So complication, deformity, arthritis, contractures, anemia, etc. So investigations, you do blood test, bleeding time will be normal, clotting time will be increased. It doesn't clot fast. Prothrombin time is normal. APTT time, activated partial thromboplastin time, will be increased. This leads to clotting time increased. Fibrinogenesis will be normal, prothrombin time normal, platelet count will be normal. Factor 11 assay is used to assess levels and severity. So radiology is done in cases of hemarthrosis. Synovial thickening, demineralization, erosion and contracture will be seen. Increased vascularization of the joint space, premature appearance of ossification centers may also be seen, and complete destruction of reticular surface and formation of juxtaarticular cysts. Then you have antenatal diagnosis. It's possible at 18 to 20 weeks of gestation. Fetal blood and demonstration of low procoagulant component of factor 8. PCR technique, you have an oligonucleotide primers you have. So treatment, you have severe bleeding, you give fresh whole blood. Compression, you give pressure bandage. Mild to moderate bleeding, you give fresh frozen plasma. Factor 8 concentrate recombinant factor 8, desmopressin and dranazole you provide. Antifibrinolytic, tranexamic acid, epsilon amino caproic acid you provide, and local thrombin powder also you provide. So that's it. Then we move on to leukemias, which is malignant neoplasms of hematopoietic stem cells arising in the bone marrow. Acute myeloid leukemia seen in more than 60 years of age due to Down syndrome, Patau syndrome, Klinefelter syndrome, ataxia telangiectasia, Bloom syndrome, Faulkner's anemia, radiation, etc. So FAB classification, you have all the different levels, M0 to M7. 0 is minimally differentiated, 1 is without maturation, 2 is with maturation, 3 is promyelocytic, 4 is myelomonocytic, 5 is monocytic erythroblastotic and megakaryocytic, 6 is RBC, 7 is megakaryocyte, 5 is monocytic. 1, 2, you can remember it as minimally differentiated and without maturation, with maturation. Okay. Then you have monocytic, promyelocytic is 3, myelomonocytic is 4, monocytic is 5. That's how we can remember AML. It is FAB classification. I forget what FAB is. Yeah, no idea. So, in cases of symptoms, you have fatigue, weight loss, anorexia, bruising or bleeding, bone pain, granulocytic sarcomas, and chloromas. So, signs, you have lymphadenopathy, hepatomegaly, splenomegaly, uh, infection, I think so. Okay, fine. Hemorrhage and DSC. Okay, so give me a minute. I'll come back. My voice is hurting for a bit. So, yeah. Hmm. Okay. So, yeah. Moving on, we go on to investigations in AML, acute myeloid leukemia. So we're at page number 92, and there is another book which has another 78 pages. Hmm. I guess there's nothing I can do. I just have to suck it up and finish it off in ideally I want to finish it off in like 4 hours, and then remaining 1 hour I can do CNS and infections, but more likely than not even psychiatry I need to do. Infections, I have like a small list of topics I want to finish, but psychiatry I really psychiatry might take some time. Fine, let's go on. So yeah, in case of investigations, you have RBC, you have pneumochromic pneumocytic anemia, WBCs will be elevated. You have thrombocytopenia, you have bone marrow examination, you get 24% blast cells, or you have neutrophilic needle-like structure in cytoplasm of myeloblastic cells, and serum uric acid will be and LDH will be elevated. So management, you have induction, you have cytarabine with anthracycline with or without ipavoside for induction period. During post emission management, you give high dose cytarabine every alternative days, and bone marrow transplantation for allogenic, which is allogenic or autologous, can be provided. Okay, then going on to chronic myeloid leukemia, whereas AML was common in more than 60 years of age, this is common in 25 to 60 years of age. So cytogenics, you have Philadelphia chromosome. It is a reciprocal translocation between 22 and 9. So ABL fragment of chromosome 9 joins the breakpoint cross cluster BCR fragment. So fusion codes for protein with tyrosine kinase activity. So clinical features, you have fever, lethargy, anorexia, weight loss, abdominal discomfort, massive splenomegaly will be there, splenic friction rub, which indicates splenic infarction, lymphadenopathy will be there, and cutaneous infiltration will be there. So investigations due to normocytic normochromic anemia, thrombocytopenia, WBC count will markedly raised, leukocytic alkaline phosphatase will be absent in granulocytes in um, CML, and uric acid and alkaline phosphatase will be increased. Serum B12 is increased. There is increase in transcobalamin, which is present in neutrophil granules. Bone marrow also will show hypercellularity. So the management is allogenic or synergic bone marrow transplant. So tyrosine kinase inhibitor you can provide imatinib, nastanib, and nilotinib. So alpha interferon induction is given for induction and maintenance of remission. Leukapheresis, that is you take out the WBCs and you provide WBC another type, and splenectomy can be done. So because there is tyrosine kinase activity, that's why you give tyrosine kinase inhibitor. If there was no tyrosine kinase activity, you do not provide the tyrosine kinase inhibitor. Okay, then going on, acute lymphoblastic leukemia more in 3 to 7 years old. Males is more than female. It is caused due to radiation, Down syndrome, Bloom syndrome, Fanconi anemia, ataxia telangiectasia. So viruses, Epstein-Barr virus and STLV. Even T lymphocytic virus. Again, you have FAB classification 1, 2, 3. This is small blast, scant cytoplasm, large blast, abundant cytoplasm, and variable sized blast with oculated cytoplasm. That's how you should remember actually. Small, large, variable, then it is scant, abundant, and vacuolated. So clinical features, you have fatigue, pallor, petechiae, fever, mucosal bleeding, bone pain, and arthralgias, splenomegaly, hepatomegaly, lymphadenopathy, and signs of increased intracranial tension, which is leukemic infiltration of the meninges. So complications, you have aplastic anemia, renal failure, hypoglycemia, and bone marrow necrosis can be seen. Going on to investigations, we have anemia will be there, thrombocytopenia will be there, WBC count will be less than 10,000, peripheral smear will show lymphoblasts, bone marrow will show malignant lymphoblasts, X-ray will show cortical defects, CSF analysis will be leukemic cells will be there, and uric acid will be elevated generally. Thrombocytopenia will be less than 10,000 per millimeter cube. Peripheral smear will show lymphoblasts, then bone marrow will show malignant lymphoblasts, X-ray will be cortical effects will be there, and CSF analysis will show leukemic cells. So management going on, induction you provide with L16 plus L-asparginase with daunorubicin. That is for induction. Whereas in here it is only alpha interferon, and here it is citrablastin, citrabine, and anthracycline. Here you have vincristine, and consolidation you give methotrexate, meropenem, mercaptopurine, and cytarabine and cyclophosphamide. Maintenance you give 6 mercaptopurine. CNS prophylaxis you give intrathecal methotrexate. Then you have chronic lymphocytic leukemia, CLL, which is seen in age more than 45 years. So you have again staging 1, 2, 0, 1, 2, 3, 4. Zero is absolute lymphocytosis, which is 10 power 9. There will be a very much raised lymphocyte count. This is 10 power 9. the faintest. Yeah. This is for my OCD's sake. Okay. Good. Okay. Absolute will be, of course, of absolute lymphocytosis. Then you have enlarged lymph nodes, you have enlarged spleen or liver, you have anemia less than 11 gram per deciliter, and you have platelets with or without organomegaly. One size larger. Okay. So absolute lymphocytosis, enlarged lymph nodes, enlarged liver or spleen. You have anemia less than 11 gram per deciliter, and you have platelets which is less. With anemia and organomegaly. So clinical features, you have weight loss, infection, bleeding, large rubbery non-tender nodes, and hepatosplenomegaly. So investigations, you have Combs positive hemolytic anemia. WBC count is 50 to 200 into 10 power 9 or 50 to 200,000 per microliter. Thrombocytopenia will be there, total protein and immunoglobulin will be decreased. B lymphocytes will fail to produce antibodies. So management is ibrutinib, flufarabine with cyclophosphamide and obinutuzumab. Obninuma. What do you call this, man? Forget. Then you have immune thrombocytic purpura. Immune thrombocytic ITP or idiopathic thrombocytic purpura. Yeah, idiopathic. Thrombocytopenia of non-etiology, idiopathic. Production of antibody against platelet associated with lymphoma, CLL, HIV, and connective tissue disorders. So, clinical presentation, you have bleeding, epistaxis, bruising, hematuria, dysfunctional urine bleeding, GI bleeding, and petechiae and purpural ecchymosis. Diagnosis, you have thrombocytopenia, antiplatelet antibodies, and bone marrow, you can have megakaryocytic hyperplasia. Treatment, you provide prednisolone, splenectomy if platelet count is less, and intravenous immunoglobulins and thrombopoietin, which is romiplastim, eltromopag. Not sure why, but you provide thrombopoietin. Then you have deep vein thrombosis, which is phlebothrombosis. So it is a semi-solid clot in vein with high tendency to develop pulmonary embolism and sudden death. Semi-solid clot in vein. So we can have trauma to leg, ankle, and thigh. Immobility, if it is there, then yeah, it is a problem. Bedridden patients, long distance travelers who stand a lot, pregnancy, puripurum, oral contraceptive pills usage, polycythemia, deficiency of antithrombin protein C and protein S, factor V Leiden mutation. So sites, you have internal iliac vein, iliofemoral and femoral vein, popliteal vein, soleal vein, axillary vein thrombosis. So clinical features, you have fever, warm, tender, shiny swelling in the calf. You have Homan sign, dorsiflexion of foot with extended knee causes tenderness in the calf, and Moses sign, which is gentle squeezing of lower part of the calf, is painful, but you have clot dislodgement risk, so you don't do Moses sign. So features of pulmonary embolism: you have chest pain, breathlessness, hemoptysis. Litens test is application of tourniquet at sacrophumeral junction. Patient is made to walk without moving the tourniquet. After the walk, limb is elevated. If there is a prominence of superficial veins, then it indicates deep vein thrombosis. I mean, features of the pulmonary embolism, you remember. Moses sign is painful. Dorsiflexion of foot with extended knee is tenderness and cough. That you should remember. But okay, then after this make to walk, limb is elevated, prominence will be said. Another thing is there, which is you provide a stocking when he is made to wear the stocking from the heel to the wherever shin, wherever it comes up to, and you tell them to walk. If they develop pain while walking, then it is DVT pain. So investigations: you have venous Doppler with duplex scanning and venogram, radioactive iodine, 125 fibrinogen study, ventilation and perfusion scanning. Treatment: you have wrist bandaging the entire limb with crib bandage. Anticoagulants you provide, which is no molecular weight heparin, warfarin, and phenindone. Fibrinolysis for streptokinase. Fibrinolysis, which is streptokinase, and you give thrombectomy using Fogarty's catheter. Inferior vena cava filter also you can provide, which prevents thrombus from reaching the heart, and palma operation. In iliofemoral thrombocytosis, femoral vein below the block is anastomosed to the opposite femoral vein. So you have May Hansen operation in popliteal vein thrombosis. Popliteal vein below the block is anastomized to the long saphenous vein. That's it. Then you have disseminated intravascular coagulation. It is a consumptive coagulopathy disorder occurring as a secondary complication in some diseases, which is like infections like sepsis, meningococcemia, histoplasmosis, malaria, aspergillosis. It can be neoplasm of pancreas, prostate, stomach, lung. Obstetric complication also can be there: septic abortion, rupture placentae, amniotic fluid embolism, massive trauma, burns or surgery, snake bite, shock, heart, heat stroke, liver diseases. All of them will cause DAC. Then you have triggering mechanism. Which is okay, so you have some triggering mechanism, which is in a tissue factor and neurotoxin, which activates the coagulation cascade, and DIC with fibrin deposition occurs in microvasculature. This in turn leads to secondary fibrinolysis, consumption of platelet and coagulation factors, and organ damage like brain, kidney, renal failure, gangrene of digits and genitalia and nose. Secondary fibrinolysis and the consumption of platelets and coagulation factors lead to bleeding manifestation like skin and mucous membrane, operation sites, veiny puncture site, GI bleeding, hematuria, and uterine bleeding. Again, this organ damage leads to hypotension, which leads to bleeding manifestations. Investigations: you have platelet count like thrombocytopenia, prothrombin time, which will be prolonged, PTT will be prolonged, clotting time will be prolonged, fibrinogens level will be low, D-dimersemia, urine will be increased, and peripheral film you will see cystocytes. And management: you treat the underlying cause, correct the precipitating factors like acidosis, dehydration, and hypoxia, correct platelet or factor deficiency, and prevent sudden catastrophic hemorrhage, GI or intracranial bleeding. Then we move on to splenomegaly, which can be mild, moderate, or massive. Mild is generally due to congestive cardiac failure, malaria, typhoid, miliary tuberculosis, leptospirosis, HIV, infective carditis, septicemia, rheumatoid arthritis. Massive is the only thing. Causes of massive splenomegaly: CML, myeloid metaplasia, myelofibrosis, Erythroid leukemia, Neal Pink disease, thalassemia, major chronic malaria. Enough. Congenital syphilis, sarcoidosis, gastroschisis. Okay, that's all, bro. You cannot really remember more than 6. 6 is more than that's all they'll ask. Application of stem cell transplantation you can have for malignant and non-malignant. So, non-malignant condition, you have inherited metabolic disorders, inherited immune disorders, inherited red cell disorders, failure states, and autoimmune diseases. And malignant condition, you can have acute and chronic leukemia, plasma cell myelodysplastic syndrome, and plasma cell disorders. So, inherited metabolic condition like adrenoleukodystrophy. Inherited immune condition, SAID, you have. Red blood cell, you can have beta thalassemia, aplastic anemia, Fanconi anemia, autoimmune, marrow failure states, aplastic anemia, Fanconi anemia. If autoimmune diseases, you can have systemic sclerosis, multiple sclerosis, lupus, juvenile rheumatoid arthritis. So various characteristics of stem cell is given. Yeah, that's all. So finally, we talk about poisoning. Paracetamol, barbiturate, benzodiazepine is same. OP poisoning, yes. Methanol poisoning, yes. Cyanide not required. Carbon monoxide maybe. I'll just do it off. Plasmapheresis, methimoglobin, chelating agents. Then acute illness, you do shock full. I'll do. SIDS, yes. Then septic shock, yes. Anaphylactic shock also, yes. Syncope, delirium, I'll do once. Acute respiratory distress syndrome, yes. Mechanical ventilation. And yeah, this much I have to do. Within like another half an hour I'll finish it off. Then I go to the next book. That one will take, by the time it's 10 I'll finish that one, and after I'm done with both of them I'll see the question banks. I'll just keep on doing the question banks and last year questions. Malaria, Parkinsonism. Okay, yeah. Very, very fast I can finish. Tell me another thing else I want to finish. Alright, so going on to paracetamol, acetaminophen poisoning, we have recommended dose. Adults is 650 to 1 gram every 4 to 6 hours. Children is 15 mg per kg every 6 hours. So toxicity adults is 7.5 grams a day. Children it is 40 grams per day. Give me a second. 3 hours of studies left today. So within 3 hours, I need to finish all poisoning. I need to finish all acute phase shit. But most importantly, I need to finish cardiovascular system and renal system. So genuinely, I'll come back. I'll come back. I'm going to finish off cardiovascular system first because cardiovascular system is the most important system, bro. Literally, if you do this, large amount of other things you can leave it off. Let me remove the screensaver and help you guys watch. CVS itself is like 43 pages and I need to do all of it. I'm so fucked if I don't. Endocrinology is okay, doable. Actually, just a second. I need to check something out. Okay, so we're back. Yeah, these 3 topics are very much important and these 3 topics I'm not very good at. But I'm going to finish it off. Okay, fine. No, I'll finish it off after this. No, this is 5 marks. So okay, I have to finish everything anyway. So cardiopulmonary resuscitation. It is a patient with acute pulmonary or respiratory failure or both. So it excluding the newborns, basic reports are CAB, circulation, airway, breathway. So faces upward, totally unresponsive, then gently shake and all do shit. Then look, feel for breathing. Do not give rescue breaths first. It delays the vital chest compression. Needs to increase in mortality. So check for pulse for 10 seconds. If there is no pulse, start chest compression first of all. Then do not perform jaw thrust. It delays chest compression. And chest compression will perfuse the vital organs and it will not convert arrhythmia back to normal sinus. Okay, so you give high quality CPR, uninterrupted chest comfort, 5 to 10 5 centimeter or 2-inch depth at 100 per minute. So decrease intervals and between stopping chest compression and shock delivery, 30 compressions to ventilation. That is a rule. So congestive heart failure, CHF, is failure of heart to maintain sufficient circulation to provide adequate tissue oxygenation. So it features both right and left heart failure. Preload is left ventricular and diastolic pressure, depends on left ventricular compliance and venous return. Afterload is left ventricular systolic wall tension developed by aortic wall resistance and blood vessel resistance and elasticity. So precipitating factors, you have hypertension, diabetes mellitus, cardiotoxic substances like alcohol, tobacco, and cocaine, hyperlipidemia, thyroid disorders, persistent tachycardia, coronary artery disease, and anemia. So pathophysiology, you have heart failure, changes in vascular function, blood volume, and neurohumoral status occur throughout the body. Compensatory mechanisms are there which maintain cardiac output, which is Strang's Sterling mechanism, and arterial blood pressure, which is venous systemic vasoconstriction will happen. So compensatory changes over time can worsen cardiac function. Compensatory mechanisms are cardiac. You have Franz Sterling mechanism, which leads to tachycardia, ventricular dilatation, neuronal increases of sympathetic adrenal activity and reduced cardiac vagal activity. Hormonal is activation of RAAS, vasopressin, catecholamine, and natriuretic peptides. So cardiac changes include during heart failure include end diastolic volume will be increased, ventricular hypertrophy or dilation is seen, decreased stroke volume and cardiac output, reduced ejection fraction will be there, systolic dysfunction, impaired filling is there, which is ventricular dilation dysfunction, diastole dysfunction. Okay, so impaired left ventricular function, decrease of stroke volume, and okay, look, there is decrease in stroke volume and cardiac output. It leads to renal perfusion, decreased renal perfusion, which leads to sodium and water retention, which leads to increased blood volume and peripheral edema, and increase in the left ventricular filling. That is the first pathway. The second thing is renal perfusion will increase okay, look, as this happens, there is reflex arteriolar vasoconstriction because of reduced output and stroke volume. This both renal perfusion reduces, which leads to reflex renin, angiotensin 2 increases, aldosterone increases, and vasopressin increases. Okay, all of these will increase, all of these hormones will increase. It leads to sodium and water retention, it leads to increase in the blood volume, it leads to peripheral edema and increase in the left ventricular filling. Okay, then there is reflex arterial vasoconstriction. This again leads to increased systemic vascular resistance, which leads to increase afterload left ventricular impedance and impaired left ventricular function. Left ventricular filling will increase and it will impair. Increase systemic vascular resistance. Yeah. So that is the thing. Left ventricular will become hypertrophy and it will become dilated. Then you have decreased stroke volume and cardiac output. Ejection fraction will be reduced, systolic dysfunction, and filling of diastolic blood will be impaired. High end diastolic volume will be there. End diastolic volume will be very high. So yeah, you also have compensating mechanisms here. Frank Sterling, sympathetic adrenergic, there is cardiac vagal, hormonal activation of nerves and stuff. Okay, moving on, classification of cardiac failure. You have forward and backward heart failure. Forward heart failure is due to inadequate discharge of blood into arterial system, leading to poor tissue perfusion, poor renal perfusion. Okay. Backward heart failure is failure of one or both ventricle to fill normally and pump blood, leading to elevated arterial and venous system pressure behind the failing ventricle. Then you have high output and low output failure. High output failure, low output failure. So heart fails to maintain normal um, fails to maintain normal or increased output during increased requirements. Anemia, hyperthyroidism, Peyer's disease, arteriovenous malformation, and pregnancy. So features of right ventricular failure predominate at first, but later left ventricular failure occurs. So first it is right ventricular failure, then it is left ventricular failure. So low output failure is heart fails to generate adequate output. Examples include intrinsic myocardial disease, chronic excessive afterload, excessive preload, negative inotropic drugs, restrictive filling, and extreme bradycardia. Okay, so you have cardiomyopathy, ischemic heart disease, myocarditis, Chagas disease, etc. Chronic excessive afterload. If the afterload is excessive, okay. High output failure is just normal or increased output during increased requirement. That's it. Heart failure, no. Forward is arterial system is inadequate discharge, poor tissue perfusion and renal perfusion. Backward is ventricles do not fill normally and pump blood. Elevated arterial and venous system pressure behind the falling out ventricle is seen. Low output is heart failure fails to generate adequate output. It may be because of cardiomyopathy, ischemic heart disease, myocarditis, Chagas disease. Chronic excessive afterload like aortic stenosis, hypertension can lead to low output failure. Chronic excessive preload like mitral regurgitation, negative inotropic drugs, antiarrhythmic drugs you can provide, restricted filling like constrictive pericarditis, restrictive cardiomyopathy, extreme bradycardia like beta blocker, and complete heart block. Okay. Next, right and left sided heart failure. So right sided heart failure, you have peripheral edema, abdominal discomfort, raised JVP, and hypotension. Left, no evidence of pulmonary edema in right sided heart failure, and abdominal discomfort, you have congestive hepatomegaly. Left sided heart failure, you have most prominent sign is pulmonary edema. You have tachypnea, tachycardia, and S3 sound will be heard, pulses, alternance, and cardiomegaly. All of them will lead to left sided heart failure. Half of them is seen in left sided heart failure. In congestive cardiac failure, there is features of both right and left sided heart failure. Decrease in hypertension, the abdominal discomfort, congestive hepatomegaly, peripheral edema, no evidence of pulmonary edema. Here you have pulmonary edema. This is one important point. Then you have systolic and diastolic failure. Heart failure with decreased ejection fraction, systolic heart failure, systolic dysfunction. So you do echo, which shows loss of contractile strength of myocardium. You have ventricular dilatation, decreased ventricular emptying. Usually ejection fraction is then 45%. Then chest X-ray will show enlarged cardiac silhouette, example of ischemic cardiomyopathy and dilated cardiomyopathy. So heart failure with preserved ejection fraction or diastolic heart failure, if you do echo, you will find filling defect in one or both of the ventricles. You have thickened ventricles and emptying capacity is normal. Ejection fraction is more than 45%. Okay, ejection fraction is normal. Chest X-ray will show that it is normal, whereas it will be enlarged cardiac silhouette will be seen in decreased ejection fraction. So examples, you have hypertensive heart disease and infiltrative cardiomyopathies, whereas in previously it was ischemic cardiomyopathy and dilated cardiomyopathy. Exactly what they have told. Cardiac silhouette, this thing, normal cardiac silhouette will be there. Hypertensive capacity is more, ejection fraction is more, ejection fraction is less. Ventricular dilatation is seen in systolic dysfunction. ventricular dilatation. Thickened ventricle is seen. Filling defect in one or both ventricle is seen. Emptying capacity is normal though. Ejection fraction of volume which is ejected will be normal, but actual volume will be less. You can assume. In systolic and diastolic. Yeah, percentage is less. Okay. Left ventricular pressure is more, left ventricular volume is less. Left ventricular volume is more, left ventricular pressure is less. It is systolic. Okay. So diastolic heart failure is more common in elderly, any age group, more often in female, more often in male. Diastolic left ejection fraction will be preserved, decreased, which is less than 40. Cavity size in diastolic is normal, dilated. In chest X-ray, congestion will be seen. Cardiomegalies with congestion is seen. Congestion with or without cardiomegaly in diastolic. Diastolic is obvious. Cardiac silhouette also is seen in systolic. Enlarged cardiac silhouette is seen in systolic, normal cardiac silhouette. Okay, then Gallop rhythm, third heart sound. This of course is fourth heart sound in diastolic, third heart sound in systolic. Okay, so clinical features, you obviously have dyspnea, abnormal, uncomfortable awareness of breathing, class 1, 2, 3, 4, NYHA. Symptoms with no symptoms with ordinary activity, slight limitation of physical activity, marked limitation, symptoms are test. Slight limitation, marked, symptoms are test. That's all you should remember. Orthopnea is pain in decomposition, which is relieved by sitting up. Relieved by sitting up, head elevation. So within 1 to 2 minutes after resuming decompetency, recovery and sit-up is immediate. So mechanism is increased venous return, fluid shift into intravascular compartment, elevated diaphragm is in lying position, decreases the vital capacity of the lung. Okay, then you have paroxysmal nocturnal dyspnea at night and awaken the patient from sleep. 2 to 4 hours after sleep, you have 10 to 30 minutes will take, and there is decreased sympathetic support to the left ventricular function during sleep, and there is fall in partial pressure of oxygen. If there is an increased venous return, fluid shifts into the intravascular compartment, elevation of the diaphragm in the lying position will lead to decreased vital capacity of the lung. Sympathetic support will be less. Fall in PaO2, sympathetic support to left ventricle decreases. Then venous return will be increased and diaphragm will be elevated in lying position. Tripopnea, left or right, no one cares. Cardiac asthma is wheezing secondary to bronchospasm. That's it. No problem at night, no one cares. Acute pulmonary edema is severe cardiac asthma. Marked elevation of pulmonary capillary pressure leading to alveolar edema, characterized by dyspnea, cough, copious, frothy, pink, frothy expectoration and bilateral crepitation. You have Kyle-Stokes respiration, alternative period of hypoxia and hyperventilation, diminished sensitivity of respiratory center, prolongation of circulation time. Nocturia is better due to better renal perfusion and diuresis at night when patient is supine, and cerebral symptoms you have mechanisms, arterial hypoxemia, reduced cerebral perfusion. You have confusion, memory impairment, insomnia and anxiety. So physical findings, you have pulmonary rales, pulmonary peripheral edema, ascites, hepatomegaly, jugular vein distension, displaced apical impulse, abnormal heart sound. So SC or S4 is known as triple rhythm, S1, S2, S3 by S1, S2, S4 or S1, S2, S4. Okay. One of those two, you have triple rhythm. Presence of both S3 and S4 is quadruple rhythm. Summation gallop is S3, S4 merge, sounds like triple rhythm. These are just findings in heart failure. S1, S3 will be there. Abnormal apical impulse. So you have systolic heart failure, you'll be having abnormal apical impulse. Jugular venous distension, of course. Congestive hepatomegaly, if it is in peripheral edema by pulmonary rails. So for diagnosis, you have to do echocardiogram. You determine the ejection fraction, determine valvular heart disease, other cardiac anomalies also. You have to find out dilated ventricle, thickened ventricles, etc. So cardiomegaly, vascular redistribution, Kelly B lines, interstitial edema. Echocardiogram, you have ventricular hypertrophy, ischemic heart disease, arrhythmias, and conduction delays. So brain natriuretic peptide type B natriuretic peptide is best to rule out congestive heart failure secreted by heart in response to excessive stretching of myocytes. Screening tool in evaluation with decompensated heart failure is always elevated in patient with 97% sensitive, most sensitive. And normal BNP excludes CHF as the cause of dyspnea. Exception is obesity. BNP can be falsely low. BNP lacks specificity. So renal failure can lead to elevated BNP. Positive BNP warrants a follow-up echocardiogram. So management of systolic congestive heart failure. Reduce intake of salt. Calculation of fluid intake and excretion in the hospital. Monitoring the body weight in outpatient setting. So you provide EC inhibitor. Captopril, enalapril, lisinopril. So they cause vasodilation. Reduce preload and afterload. Reduce right arterial, pulmonary artery, and pulmonary capillary wedge pressure. I think that's what it is. ARI receptor blocker. You have valsartan, telmisartan, etc. Valsartan is an ARB. Sacubitril inhibits neprilysin. Inhibits degradation of ANP, BNP, and bradykinin. Inhibition of blocks RAS system leading to natriuresis and decreased cardiac hypertrophy and fibrosis. Then you have ivabradine, which is used for heart failure and tachycardia, unresponsive to beta blocker, inhibitor of I funny channel. It slows the heart rate by decreasing the sinus node automaticity. Then you have vasodilators, which is nitroprusside, alveolar and venous nitroglycerin, which is venous arterial at high doses of IV, isosorbide dinitrate, which is venous, and hydralazine, which is arteriolar. All of these are vasodilators. Then you have diuretic therapy. You have loop diuretics, furosemide. Treatment of choice for acute pulmonary edema. Treatment of choice. Then you have thiazide diuretics, which is hydrochlorothiazide, spironolactone, aldosterone agonist, add-on therapy to ACE, add-on therapy to ACE inhibitor. Oh my god. I'm just really tired, man. There's 43 pages of this I have to do. In 3 hours I can finish 43 pages. How long have I been doing this? 23 minutes, you did 7. So in that case, 23 times 7 again. 1, 2, 3, 1, 2, 3, 1, 2. Yeah, I can finish off everything in like 10 times. 10 times the half an hour, which is like 5 hours. It will take 5 hours minimum to finish. Actually, give me a second. Hmm. Okay, I decided I'll not do respiratory system, but I'll do everything else. CVS, RS, everything. Some infectious diseases I'll do off, but I'll have to finish cardiac first. Hmm. Okay. Beta adrenergic blocking, metoprolol, carvedilol, bisoprolol, along with AC inhibitors. Beta blockers decrease mortality, increase ejection fraction. Beta blockers are contraindicated in cardiogenic shock and active asthma. Automatic implantable cardio defibrillator indicated in severe ischemic dilated cardiomyopathy. Ejection fraction is less than 35%. Biventricular pacemaker is cardiomyopathy with QRS more than 120 millisecond. Pacemaker if require pacemaker activity. Anotropic effect digitalis in patient with severe heart failure improves symptoms and all quality of life. So management of severe systolic congestive heart failure, you have sympathomimetic inotrope amines, which is dobutamine, phosphodiesterase inhibitor, which is amrinone, milrinone, extracorporeal membrane oxygenation, ECMO, biventricular assist device if patient is awaiting heart transplantation, of course. Management of diastolic heart failure, thickened ventricles, preserved ejection fraction. No effect from inotropic agent since the cardiac contractility is normal. So you provide diuresis, BP control, and exercise. So management is just that. In cases of systolic, you give sympathomimetic, phosphodiesterase, extracorporeal. Then refractory cardiac failure, silent myocardial infarction, non-venous stenosis, pulmonary embolism, thyrotoxicosis, left ventricular aneurysm, biliary anemia, myocarditis, infective endocarditis, arrhythmias. All of these are refractory cardiac failure. Basically, just keep on telling every single thing you can remember. Silent MI you can remember, pulmonary emboli you can remember, thyrotoxicosis, yeah. Infective endocarditis, myocarditis, cardiac tamponade, arrhythmias, massive hemothorax, SA or AV nodal dysfunction. Digitalis is cardiac glucoside. It is an inotropic agent preferred in severe heart failure, improves symptoms and quality of life. So mechanism is increase intracellular concentration of sodium, decrease exchange of intracellular calcium for intracellular sodium. It results in increase in intracellular concentration of calcium, which gives positive inotropic effect. So it is used in systolic heart failure, atrial fibrillation of flutter, paroxysmal arterial tachycardia, or SVT. So toxicity monitoring you have to do. Serum potassium should be carefully monitored. K plus and digitalis compete for myocardium binding sites. Hyperkalemia will decrease digitalis action. Hypokalemia increases the digitalis toxicity. Toxicity you have to monitor a lot. Other condition which predispose to digitalis toxicity is renal insufficiency, electrolyte disturbance, cyanoarterial and AV block, hypothyroidism. So toxic effects of digitalis, you have nausea, vomiting, gynecomastia, yellow arrow around an object, and arrhythmias. Okay. Treatment of intoxication, stop the drug, lidocaine, phenytoin, diazebind, acute overdose. Then JVP. JVP is expressed as vertical height from sternal angle to the zone of distension of till the zone of distension of internal jugular vein. So right IGVT is preferred, longer, straighter, and has no valves. Situated between two heads of the sternocleidomastoid mastoid. Most common cause is congestive cardiac failure. So causes unilateral non-pulsatile, bilateral non-pulsatile, bilateral pulsatile. Unilateral non-pulsatile, you have innominate venous thrombosis. SVC bilateral non-pulsatile is SVC obstruction and massive right-sided pleural effusion. So bilateral pulsatile can be cardiac, pulmonary, or iatrogenic. So in cardiac cases, you have cardiac failure, tricuspid stenosis, regurgitation, constructive pericarditis, and cardiac tamponade. Pulmonary COPD, carpulmonale, abdominal ascites, and pregnancy. Iatrogenic is IV fluid excessive is the give off. Cities or pulmonary cardiac failure, tricuspid. Okay, so yeah, A wave, C wave, X wave, V wave, Y wave, again, yeah. Hmm. Abnormalities of JVP, A wave. If it is absent, it is atrial fibrillation. Absence of A wave is atrial fibrillation. Prominent A waves is Canon wave, like Canon A waves is there, prominent A waves is there. Prominent is pulmonary stenosis, pulmonary hypertension, tricuspid atresia stenosis. Canon A wave, you have regular, you have jugular junctional rhythm. Irregular, you have multiple ectopics and heart block. So V wave prominent will be tricuspid regurgitation. X wave descent prominent is constrictive pericarditis. Pay text. Y wave descent is slow in tricuspid stenosis, fast in tricuspid regurgitation. Absent is cardiac tamponade. Very well known acronym pay tax. So in cases of tamponade, pay tax. So cardiac tamponade, you have pericarditis. Wait. I have to just check this out again. They haven't explained this properly here. Yeah, they haven't explained this properly, so give me a second. I'll check it out somewhere else. So, Kesselman sign is inspiratory increase in jugular venous pressure. It's caused by constrictive pericarditis, restrictive pericarditis, right ventricular infection, left ventricular failure. So you also have Frederick sign, which is rapid, wide descent and rise of JVP seen in constrictive pericarditis and tricuspid regurgitation. So your kidneys. Angiotensin 2, that's the most important thing. It leads to vascular constriction, blood vessels, venoconstriction, adrenals release catechol, release aldosterone, sodium and water retention, K plus loss. That's only important. In glomerulus, you can have constriction of efferent and afferent arterioles. That's it. That is 82. Then aminopeptidases will lead to formation of ET3 and 4, similar but enhances coagulation here. Everything else is similar. Kidney has renin, which is AT1. Lungs have ACE kinase. The angiotensin converting enzyme ACE1 to AT2. Liver produces angiotensin. That's one important thing. So, call pulmonis is enlargement of right ventricle with or without failure secondary to disease of thorax, pulmonary circulation. So, etiology can be COPD, asthma, pulmonary TB, interstitial lung disease, diffuse bronchiectasis, cystic fibrosis, pleural fibrosis, etc. And disease of thorax can be kyphosis, neuromuscular disorders, sleep apnea, obesity. Diseases of pulmonary circulation is recurrent pulmonary thromboembolism, primary pulmonary hypertension, collagen vascular diseases, and chronic liver disease. So COPD is chronic bronchitis and emphysema, accounts with more than 50% cases of call pulmonary. Chronic bronchitis, you have erythrocytosis edema, early onset of call pulmonary, blue blood loss, and call pulmonary will occur later in emphysema. So pathogenesis, you have hypoxia, which leads to polycythemia, hypoviscosity, and acidosis and hypercapnia, which again leads to pulmonary hypertension. Along with reduction in pulmonary vascular blood, it leads to pulmonary hypertension, which leads to hypertrophic dilatation of the right ventricle. Because there is high pressure in the left ventricle pulmonary artery, the pressure will make it so that the blood cannot pump. It's there only. It will be there in the right ventricle only. Right ventricular failure will eventually lead to after car pulmonary symptoms. So it will There is an overlap of symptoms between carpal pulmonale and COPD, but dyspnea not controlled by sitting up due to pulmonary hypertension. Dry cough will be there, fatigue will be there, anterior chest pain due to dilatation of the root of pulmonary artery. Excess is induced by peripheral cyanosis and daytime somnolence, similar to hepatic. What is it? Toxicity, encephalopathy. Okay, so signs here: tachypnea, ankle edema, prominent A wave, right ventricular heave will be there, loud P2, right sided S4 will be there, and ejection systolic murmur will be there at the pulmonary area, and pansystolic murmur of tricuspid regurgitation will be there, pulmonary regurgitation is there. So pansystolic murmur will be there, early diastolic murmur will be there. Then you have overt right heart failure, in which there is increasing peripheral edema, decreasing jugular venous pressure, and positive hepatojugular reflex. You have tender hepatomegaly, cardiac enlargement will be there, right ventricular S3 and gallop rhythm also will be there. So additional clinical feature in chronic bronchitis and emphysema you can see. So chronic cough with sputum production is blue blotters, recurrent secondary erythrocytosis, and repeated episode of right heart failure will be there is second chronic bronchitis. But in emphysema, cough and sputum production less prominent, severe exertional dyspnea, erythrocytosis is uncommon, right heart failure also occurs very late. So secondary erythrocytosis is there. Okay. Investigations: chest X-ray, prominent right ventricle, right artery, and right ventricle and pulmonary artery. ECG, P pulmonal, right axis deviation, right heart, right ventricular. RVH with the strain pattern is seen. Then blood count, you have secondary polycythemia. So management: you treat the primary lung disorder, diuretics you provide, vasodilators you provide, bronchodilators you provide, and you control the infection. Then you have pulmonary edema, which is abnormal accumulation of extravascular fluid in the lung parenchyma. Leads to diminished gas exchange at alveolar level, potentially progresses causing respiratory failure. So etiology, it can be cardiogenic or volume overload pulmonary edema, or it can be non-cardiogenic, which is non-cardiogenic pulmonary edema. Oh my god. Yeah, I have no idea how I'll finish this. Secondly, I'll have to see. If I'm not reading offline, then maybe I'll come back and start teaching. But for the time being, I'm going to study offline. Yeah.